Everybody, I'm like Melissa and others, very pleased to be here talking to you this afternoon. If we just go to this next slide, please, Carl. Just want to tell you a little bit about why I'm involved in this programme and this project. I work for Liverpool University Hospitals Trust, which was formed in 2019. It was two large organisations coming together in the centre and the city of Liverpool in the northwest of England. We're one of the largest employers and the largest providers of care in the country. We have 1,600 beds, we have 14,000 staff, and we have a 1.1 billion turnover. So it's a large organisation, which you can imagine trying to wrap your arms around that sort of organisation is quite difficult in terms of how you manage the services that you provide, but also the workforce that you have. We also, I think what's important for people who perhaps aren't as familiar with Liverpool, our overseas colleagues, we work in a very deprived area in terms of the communities that we serve, and there's a huge difference in life expectancy across the patch that we serve. We therefore have a huge responsibility within the city and surrounding area in terms of how we deploy the resources that we have, both the care that we provide for people and the workforce that we have. We also need to be aware that actually the people who work for us come from those communities in the main, and we need to actually address, when you think of how we've been describing the wants and needs of people, we need to really understand people coming to work for us and what those wants and needs are. So if you just go to the next slide, please. So like many colleagues around the world, we are facing numerous challenges, and we need to think differently about how we approach these. So, in a world post-COVID, we have staff that are burnt out. We have high workloads in terms of restorative, our elective recovery programmes. We have staff survey results that suggest that NHS staff who were once revered and clapped in England post-COVID are now sort of worn to the ground and need to be cared for and looked after. We also have competing priorities. The need to do things differently has never been more obvious or challenging. And we talk about, Dame Jo talked about the long-term workforce plan. If you look at the workforce, if you look at delivering that and how we're going to deliver the increased numbers in the long-term workforce plan, people say that the workforce that we need for the future is the workforce that we have today. So we need to really look after that workforce and mould and develop and invest in that workforce to make sure that we can continue to deliver the services. What we're seeing is that by not addressing some of these challenges, we are seeing a loss of productivity. And that is a constant challenge for us, coming from our government, from our Department of Health and Social Care, that we're constantly being challenged to be more productive, do more with less. So we need to think how we're going to do that, because the demand for our services is not going to reduce. If you go to the next slide, please. So traditionally in the NHS, we have developed our strategies and our thinking. If you start from the left to the right, we have started to think about, well, we get policy, we get policy from government, we get policy from Department of Health. We are told what we need to do in a lot of instances. We're then hugely the regulatory compliance, the CQC, how we are monitored in terms of our compliance against care standards is huge. We need to comply with that. We have massive financial and operational efficiency targets. We're just going through now our annual business activity planning, and the numbers don't add up. That's all I'll say at the moment. They don't add up. We then decide that we're going to create organisations to deliver this. We have organisational form that sometimes works, sometimes doesn't. Sometimes those barriers between organisations gets in the way and creates false competition or false inability to move patients easily through the system. We then create service and care models on the basis of what the policy is. So we're going to, do X amount of knee operations, for example. We then wrap our workforce around that. So we've started to, we understand what we think we need to do. We designed our service around our policy. What this work is doing, which is really what's opened my eyes, and what I'm really trying to make sure that the wider system starts to think about this differently, is if we do what Dame Jo has described, Naeem and Melissa, and think about consumer needs, behaviours and motivations, not only for our people, but for our patients as well. What do they need? And if you start from that premise, you look at strategy in a very different way. So what are the needs? What are the needs of people? So what therefore is the demand, both patients and our people that work for us? Therefore we understand what workforce we need to actually care for our people, but also what we need to put in place to care for our workforce. So it really is starting to flip how we look at strategy as a system. Next slide, please. So if we look at the work that Alder Hey have done and the work that Luft is starting to do, Liverpool University Hospitals Trust is starting to do, and we analyse our workforce differently, and we start to segment our people population in a different way, we can then start taking action. And we can start doing that in a really planned and clever way, using data, using intelligent workforce data to create OD and HR interventions to keep our staff and help build the workforce that we need to care for our patients. But we can't do that in isolation. We have to do that in a collective. And we know that we have in the UK, we have an HR and OD review, which is really clear, that tells us that we don't have the capability and capacity within our HR and OD teams to actually really do workforce analytics well. And so what we need to do is come together like we are doing today and talk about, well, how do we help each other do this? So we really need to think, if we're going to think differently, and we're going to put this challenge into the system, and we need to actually share and build the capability, the best practice, and the capacity to do this type of work. And that won't do. Luft is huge. Alder Hey is a very large organisation, wider than the Northwest. We will not be able to do this on our own. We need to create some sort of social movement that enables us to take forward this work in a real sort of with real momentum. If we just go on to the next slide, please. Art of the possible. This is what I put in front of my chief executive. This is what I put in front of my chief finance officer. This is what I've been talking to the. We work in a system of integrated care systems. So the people that commission our services, and we have to start thinking about what are the productivity gains that we can make to give a real considerable return on investment. So if we actually keep our people well, we retain our people, we decrease that churn, and we increase the productivity through well-being in terms of the people that work for us, we reduce our absence. Then if you look at that slide, I can't see I wouldn't know any chief finance officer that wouldn't want to be interested in this piece of work, which is around 9% return. Recurrent savings on a budget of 1.1 billion. To me, it's a no-brainer. So this is not just about a nice way, a clever way of looking at your people population. It's a real business opportunity that, as an integrated care system, we cannot afford to ignore. So I would end there, Dame Jo. Thank you.